And we have two folks, again, Dr. Laura Marciano is a research associate at the Harvard T.H. Chan School of Public Health in Boston, and Dr. Saboor is a doctoral student in the Department of Health Behavior and Health Education at the Harvard T.H. Chan School of Public Health, and their work addresses mental health challenges among young people globally and thinking about what can positive psychology interventions do through digital platforms. So we all know that youth mental health is probably the single greatest health priority right now. I would argue we know that technology is very exciting. We've been hearing about it, but let's see what happens when we combine youth mental health and positive psychology and technology. So I am going to give it away and then to our speakers and then put the link to the paper in the chat. Thank you both for joining us.
Yeah. Thank you, John. Thank you for the nice introduction. We are very glad to be here today. And actually, I will give the floor to Sundas, who is the first author on this paper, and I will be glad to answer to the questions in the discussion.
Hello, everyone. I am Sundas Saboor, and we will be doing a presentation on our paper, which is the application of positive psychology for digital interventions for children, adolescents, and young adults. It was a systematic review and meta-analysis of controlled trials. So mental health problems among children, adolescents, and young adults are a growing public health concern affecting 10 to 20% of young people worldwide. Advocating for a more holistic approach to mental health promotions and expanding the field's focus to include strategies for improving mental well-being are crucial to boost intervention effectiveness, prevent mental illness and relapse, and broaden our understanding of how to support individuals in flourishing and improving their overall quality of life. Positive psychology involves the promotion of well-being differentiated between hedonic well-being, which is happiness, pleasure attainment, and pain avoidance, and also eudaimonic well-being, which is related to meaning, self-realization, and full functioning of the person. PPIs, which is the positive psychology intervention, they aim to ameliorate well-being and health outcomes by increasing positive feelings, healthier lifestyle behaviors, and better cognitive functioning. Prior reviews primarily address conventional interventions such as in-person therapies within clinical settings and non-clinical settings. However, considering the ongoing digitalization of healthcare, web-based resources and mental health applications have emerged as new avenues for young adults to access healthcare services. In previous reviews, as you can see in the slide, individual meta-analysis for interventions were assessed for specifically behavior interventions or maybe EMIs. Other meta-analyses were performed for well-being components individually. For example, optimism, well-being, employee or work-based well-being, happiness, and school-based well-being. Previous researchers had no restriction on age groups, or they included adults or clinical population. For clinical population, they mostly discussed like schizophrenia, somatic disorders, severe mental illness, and chronic pain. Although these reviews provided very good in-depth analysis of effects of PPIs, but the effects of digital PPIs, specifically on children, adolescents, and young adults, have been consistently not summarized. So our objective was to comprehensively synthesize all RCTs and CTs conducted within younger population. When I say young population, it means children, adolescents, and young adults combined, encompassing both clinical and non-clinical populations in order to assess the global effectiveness of digital PPIs on individuals on this age group holistically without differentiation of prevention or treatment. In particular, we aim to carry out a systematic review and meta-analysis, and if there is any difference with respect to digital or control condition. So a detailed analysis of the search and screening methods are shown in this slide and also in the paper, but just to highlight a few points, we included studies that were either RCTs or CTs, had the intervention that was mainly based on positive psychology, which I mean by gratitude, hope, optimism, etc., as their main components. And they included children, adolescents, and young adults with the mean age of less than 35 years of age, both clinical and non-clinical populations, and they were carried out through web-based or digital or through smartphone-based interventions. Other than that, we excluded almost like everything. For example, like face-to-face interventions, psychotherapy of any kind. We excluded studies where positive psychology was not the main focus of the intervention. If, for example, control group or the experimental design was missing, if the age group was more than 35 years of age, we also excluded like abstracts, books, theses, book sections, and studies which were not conducted in English language. So a detailed analysis of the meta-analytic procedure is shown in the slide, but just to summarize, the heterogeneity of the effect size was computed with the between study variance and the Harton-Knapp adjustment, which allows to control for errors due to diversities in the sample sizes. Heterogeneity level was interpreted as low, moderate, and high, like 25, 50 to 75%. Additional subgroup analysis were also conducted to test if the effect size differed depending on the control group, like waitlist versus digital control. To further explore the effect of age, meta-regression analyses were performed by different age categories, which I said children, adolescents, and young adults, or even a combination of these categories. So this shows the prisma that we use for our study. The systematic review was basically around 35 studies. As you can see in the slide that 83% studies were conducted on general population. When I say general population, it means non-clinical, while 17% of the studies were on clinical population, like for example, non-suicidal self-injury, people who scored higher on scales of depression, anxiety, and stress, or even had a mental disorder, even undergoing children who were undergoing active cancer treatment. Around 80% of the studies were conducted in a web-based setting. 11% studies were through smartphone-based applications. 3% studies used a hybrid setting, which included both in-person and digital setting, as well as 3% studies were conducted in a telehealth setting. 13% of them were through Instagram, and around 3% used the ViviBot chatbot. 37% of the studies were conducted in Europe. When I say Europe, it includes Sweden, Slovakia, London, Netherlands, Norway, Turkey, Finland, Germany, Greece, Spain, and Austria. While 31% studies were conducted in North America, both US and Canada combined. 20% were in Asia, like India, China, Japan, South Korea. The duration of the interventions ranged from 1 week to a maximum of 12 weeks. The details of the participants' age breakdown is shown in the slides. However, if we focus more on the different controls, when we say digital controls, it involves some form of digital or web-based interaction, but did not include the full intervention content. They had access to certain activities or features, but did not receive the complete intervention that the experimental group received. The waitlist controls refer to the control groups in which participants did not receive the active intervention during the initial phase of the study, but were promised or scheduled to receive it at a later date. The waitlist control group participants do not receive the full intervention immediately and instead were placed on waitlist to receive the intervention after a specified waiting period. As you can see in this slide, that the theory that was mostly used was the broaden and base theory, which is the BBT, and it was used by around 14% of studies. The broaden and build theory basically means that certain discrete positive emotions, for example, joy, pride, and love, they share the ability to broaden momentary thought-action repertoire of people and build their enduring personal resources, ranging from physical and intellectual resources to social and psychological resources. So here you can see the breakdown of outcomes of the study. I will not go into a lot of detail, but just to summarize, well-being outcomes included mindset predisposition, which means like personal accomplishment, kindness to others, empathic concern, fantasy, partner acceptance, etc. Compassion includes self-compassion, compassion from others, and engagement. Purpose, gratitude, and hope include identified purpose, searching for purpose and meaning. Cognitive bias includes like things like tolerance of uncomfortable things, sensitivity to others, psychological flexibility, etc. Mood, affect, and emotions include well-being, positive emotions, positive affect, emotional well-being. 3 funny things, 3 good things include stuff for funny things for like happiness, cheerfulness, and coping humor. Body image related outcomes were like body image flexibility, body appreciation, satisfaction, physical activity, etc. Satisfaction and quality were more around satisfaction with life, psychological quality of life, relationship satisfaction, while coping was around emotion regulation, resilience, coping humor for cheerfulness, depression, and bad mood. Ill-being outcomes included mood, affect, and emotions, for example, depression, anxiety, emotional exhaustion, loneliness. Cognitive bias and flexibility was around depersonalization, shame, self-criticism. Stress included personal distress, PTSD, adjustment stress. Three funny things and three good things here means bad mood, depression, seriousness, etc. The body image related were around weight biases, drive for leanness, body shame, while coping was around seriousness, bad mood, and depression. So the PPIs that were used in the study are on the slides, and you can also see in the paper tables and appendix section. But just to summarize, when we talk about web-based meditation and mindfulness, it included videos and lecture for students, videos for guided meditation. There were exercises for anxiety, depression, and self-compassion, and even a mindfulness app. When positive psychology and self-compassion were discussed, there was a digital program called Better Days, which was used to boost happiness. Digital yoga was used for body image. Gratitude journaling was also used, and programs like Bite Back, it aimed to enhance well-being among young adults. For gratitude and acts of kindness, there were web-based modules, parent-child gratitude conversations through web-based tools, web-based humorous diary writing techniques were used to address happiness and depression. For optimism and positive emotion, web-based diary writing exercises were used. There was one study which used Instagram images to assess body, facial, and smile dissatisfaction. For relationship satisfaction and acceptance, web-based psychoeducation and group-based parent coaching sessions through telehealth were used. For purpose and well-being, there was one study which was by Mahalik and colleagues. They assessed the Father Project web page intervention for father's sense of purpose. There were web-based ecologic momentary interventions, that is the EMI. The Greer and colleagues studied psychological well-being among patients with cancer using BBBot, which is a chatbot designed to deliver positive psychology skills. Here, I can show you a cute picture of Bite Back, which is an online psychology website for adolescents, and it uses a combination of interactive exercises and information across many different positive psychology domains like gratitude, flow, meaning, hope, mindfulness, etc. Furthermore, this website provides information about the benefits of increasing well-being for adolescents aged 13 to 17 years of age and is pre-moderated with each comment and upload being monitored and approved before becoming available for public viewing. Here is a picture of the VBBot chatbot program. It delivers a cognitive and behavioral intervention to increase positive emotion. The intervention was originally based on the stress and coping theory and the broaden and build theory of positive emotion and focused on the teaching and practice of few positive psychological skills, like, for example, gratitude, positive reappraisal, acts of kindness, mindfulness, personal strength, etc. Here you can see the well-being outcomes showing PPIs showing improved purpose and gratitude and hope with a medium to large effect size. Meta-analysis on well-being outcomes shows that PPIs improved purpose, gratitude, and hope with a medium to large effect size. In addition, PPIs augmented the levels of compassion with no significant differences between the waitlist and the digital control group. In addition, PPIs augmented the positive coping behaviors with medium effect size. They also improved body image-related outcomes with a medium size. A small to medium effect was found for mindset predisposition. Also, a small to medium effect was also found for variable 3 funny things, 3 good things, with all studies including the waiting list control groups. A non-significant effect was found for cognitive flexibility and mood affect emotions. Satisfaction and quality of life showed a non-significant effect with no difference between the subgroups. Ill-being outcomes were less represented in the included studies. They were very few. Meta-analysis showed a large negative effect for the reduction of cognitive biases with no group differences between the waiting list and the digital control group. PPI showed a medium to large effect on the reduction of negative emotions and mood problems. PPIs also diminished stress levels. A very large effect was found for coping. However, interpretation of this result would be limited due to a low number of studies. The effect sizes were not significant for body image-related outcomes, and 3 funny things, 3 good things. For our study, funnel plots were symmetrical for the overall meta-analysis of both the well-being and ill-being outcomes, and the regression test for funnel plot asymmetry was not significant in both cases. Meta-regression analysis showed that PPIs tend to show a larger effect size on well-being outcomes in studies including young adults, while no specific effect was found for ill-being outcomes. So when it comes to well-being outcomes, PPIs enhance various facets of well-being, notably purpose, gratitude, and hope, with a medium to large effect size, as well as compassion, positive coping, and body image-related concerns with immediate effect. When we look at ill-being outcomes, the larger effect was found for diminishing cognitive biases, including self-criticism and fears, especially when participants of the experimental group were compared with the waitlist. Several studies within our review highlighted the efficacy of interventions tailored to specific settings and contexts. When age was used as a moderator, studies with young adult participants showed larger effect sizes in the meta-analysis with well-being outcomes, but no differences emerged with respect to ill-being indicators. So just to summarize, PPIs foster a sense of personal achievement and satisfaction. Digital control groups could serve as valuable benchmarks to distinguish the specific contributions of PPIs. Our results suggest that while PPIs can be beneficial, our efficacy is not universal and depends on specific intervention types and target population. In conclusion, the review found that PPIs can improve well-being in young people, specifically in areas like gratitude, purpose, and hope, but results are inconsistent across different groups and well-being outcomes. Given the variability in study quality and settings, the findings are tentative, calling for more rigorous research to understand the effectiveness of PPIs and their applicability across diverse populations and contexts. So one major limitation is the heterogeneity in study settings and targeted age groups, which range from school environments to clinical settings and included diverse demographic categories from children to young adults. In addition, the medium to low quality of some included studies potentially might undermine the reliability and robustness of our findings. In addition, an important aspect that was not covered in our review is the assessment of the safety and potential adverse effects of PPIs. For future directions, one primary recommendation is to conduct more rigorous RCTs with larger and more diverse samples. Also, we suggest that PPIs should be integrated in interventions that also collect biological information to further assess their efficacy. Another crucial area for future research is the examination of the long-term effects of these digital interventions. In addition, given the rapid advancements in technology, exploring the integration of emerging technologies like virtual reality or augmented reality into PPIs could offer innovative ways to engage and support adolescents. From a practical implementation perspective, stakeholders in the field of youth mental health should consider incorporating evidence-based digital interventions into broader mental health programs and curricula. Schools, community centers, and mental health organizations can benefit from these scalable and accessible tools, especially in regions where traditional face-to-face interventions might be limited.
Excellent.
Thank you so much for your time.
Thank you for sharing that. There's so much happening in the space, and I think you and the team summarized it very nicely. For some of you from different regions of the world, sometimes PPI also means patient and public involvement. So it's interesting how in digital health we have different acronyms and terms for different things. I think we may have time for just one very quick question, because we want to give a break until 10 after. But you looked at young people. In terms of the youngest people in your study, do you have an idea of what was the youngest group? And was anything different or working well for the very young people in this?
So one thing that I can say, and maybe Sundas, you can follow up, is that when we think about children, like some samples, they had children and teens together in the sample, so it was a bit tricky to really understand what was going on at that different ages, and that is definitely a gap that we need to fill in the future. But maybe Sundas, I don't know if you remember some specific characteristics of the intervention for the youngest.
So what we analyzed was that there was a certain age group that were analyzed a lot in research studies, which was like about teenagers and like more than 20 years of age. And most of the studies has been done in that age group. I think I showed a slide in which the different proportions of all the age categories are shown. The thing that we were struggling with is that the children who are very young, like really young, most of them were studies which always involved a caregiver and a parent. So that was more like shared. But specifically, it affects only like very young children, like for example, 5 years of age, of 6, only like including them was not part of any research study. There was always a caregiver involved.
That makes sense given the age and the ethics in doing this research, of course, too. There's so much more in the paper. Everyone has it. It has the email addresses, you guys as the corresponding authors.